This episode of The Benefit Whisperer is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget.
And welcome to the Benefit Whisperer podcast with your host, Ralph Weber. Ralph, we are in the middle of a series of episodes about the history of healthcare in America. This is episode 2. I like the title of this one. The price is what?
Yeah. What the price?
What?
WTP.
Yeah.
Yeah.
Exactly. So, I'm excited for our continuing conversation, but for those who missed episode 1, there are a couple of remedies here, and I'll remind you of both of them later today.
Mhm.
One, at first, become a subscriber because then you're automatically notified when a new episode drops. 2, you can always go back and listen to episode 1 if you did not hear it earlier. Ralph, to save people that the temptation going back and listening to episode 1 right away, can you give us a really quick recap before we dive into today's topic?
The reason that we developed this 4-part kind of mini-series, the first one was how insurance ate healthcare. Ate as in consumed. Because I believe that in order to have change, you have to understand history. You have to learn lessons from the past. And obviously we haven't. We started with the Great Depression. 1920s, hospitals were not getting paid because nobody had work, nobody had money. People would pay with chickens and eggs, etc. And then in 1929, the Baylor Teachers Plan, they decided, let's create a prepaid hospital plan. And it's going to pay for so many nights in the hospital, and you're going to pay a reasonable budgeted amount, and that's going to spread the risk a bit. Great concept. The concept of insurance already existed, so they said, hey, let's do this. So the initial premiums were slightly lower than they are today. They were $6 a year. They're more than $6 a year now, Bill, right?
They're just a teeny bit more than $6 a year.
Yeah.
Yes. I think they're a tiny bit more than $6 a second at this point.
No, exactly. Well, anyway, the problem in 1929 was that hospitals had huge debt, huge receivables that they couldn't collect. And you know what? Guess what? Fast forward almost 100 years, and the hospitals are still they've become collection agencies. The problem has gotten worse, okay? And of course, I don't know what we were spending on healthcare in 1925, but in 2025, it's over $5 trillion. So anyway, we talked a little bit about the history. We talked about some of the things that have impacted that. 1929, Blue Cross was invented. 1939, Blue Shield to pay the doctors. We talked a little bit about the McCarran-Ferguson Act, which was regulation of insurance by the states. We talked about a few things. We touched a little bit on Medicare, and we're going to dive deeper into that today. But we talked about some of the things that impacted, the cost. Did I leave any out, Bill? Was that pretty much it?
No, that pretty much covered it. I mean, we got into a little bit of the alphabets. I mean, like HMO and PPO and that kind of URSA.
Oh, yeah. HMO Act of 1973. Yeah, thanks. No, it was Kaiser Concrete Company that had their own company health plan. They invented the HMO to control costs. And people didn't like the gatekeeper model. So the revolution against that ended up with PPOs, preferred provider organizations, which were also supposed to be a slightly better model. So, again, we reinvent things. And there was a guy, Bill, I forget his name. He said the definition of insanity is doing the same thing over and over and over again. Do you remember that?
Yeah. He lived not far from me, as a matter of fact, over in Princeton. What was his name? He's a mathematician and a physicist.
Yeah.
I want to say it's something like Albert. Is that right? Albert Einstein?
Albert. Yeah, that's right. It was Al. Yeah.
It was Al. Yeah.
So anyway, We talked about how insurance became the dominant player. We talked about employers being pre-tax, managed care, and that really set the stage for price distortion. Okay.
Yeah, price
Because,
distortion, or the other subtitle, of course, of today's episode is the bills from
yeah,
hell.
hell,
So,
exactly.
listeners, I would encourage you to go back and listen to episode 1. Lots of good information in there that you may not be aware of, just to give you a sense of the history. Ralph is right. If
Mhm.
you want to talk about reform of
Right,
anything, whether it's healthcare or anything else, you need to know the history of it to give
right.
you a better understanding of where you might need to go from there.
Yes.
So, Ralph, let's start. I mean, charge masters, discounts, why are hospital sticker prices so high? Why don't we start there? The
Yeah.
insanity of healthcare costs.
Right. And it is insanity. It really is. So when Medicare started, it changed the whole pricing equation. Initially, Medicare paid based on reported costs.
Right.
Okay. So then, of course, hospitals had incentives to increase costs. Okay. Cost shifting. I think it was about 1983 DRGs, which is a diagnostic related group. It introduced fixed payments per diagnosis. Okay. So,
God
well,
love the healthcare industry and insurance,
yeah,
man. They've given us more
yeah,
acronyms than I think any other thing in America or
yeah,
in the world, as a matter of fact.
yeah, yeah. There are a lot of TLAs in healthcare. Do you know what a TLA
No,
is?
I have no idea what's a
Three
TLA.
letter acronym.
There we go. Indeed, there are a lot of TLAs, and
Yeah.
some of them more than a T.
Oh, yeah.
We could call them an M, as a matter of fact, an
Yeah.
MLA.
Yeah. So basically, what happened is we went from itemized charges to what's called the Chargemaster price, which is that crazy, ridiculous bill from hell
Mhm.
that nobody's actually supposed to pay, but some people end up doing it. Early on, the hospitals had it relatively simple. They had price lists that loosely reflected cost plus a little bit of margin, right? But
Yeah.
as Medicare and Medicaid and private insurance companies, expanded, hospitals needed a more comprehensive catalog of billing items, for reporting for getting reimbursed. So the Chargemaster evolved into a database of tens of thousands of items, and most of them bore little relationship at all to the underlying cost of care. So,
Yeah, no, I've heard from doctors plural, not
Mhm,
just one,
yeah,
from many doctors
mhm,
whose complaint about Medicare is that in Medicare specifically is that they don't get paid what the actual cost of a
right,
procedure is, which
yeah,
is why not a lot, well,
mhm,
quite a few doctors opt out of taking Medicare
yeah,
because they don't have to take it, and
mhm,
they're like, "No, I can't my practice can't sustain itself if I just
right,
take only
right.
Medicare payments."
Well, the Medicare calculates what's supposed to be the cost by doing a survey of basically all hospitals every year where they have to very, very extensive long reporting. And then they lump it all together, thousands of hospitals, and they say, here's the average cost, basically. Now, some hospitals might be able to profit at that, some lose money. So, they have one fixed, do you like that name? That word fixed? Yeah,
Yeah, yeah, I
one
mean,
fixed.
yeah, because it belies the fact that it's like the cost of, just to get crazy, the cost of a procedure in New York City is going to be significantly less than the cost of
Mhm.
those procedures in, say, Cheyenne, Wyoming.
Right, right. Yeah. No,
But we fall into the trap of this is the average,
yeah,
so
yeah, yeah,
we're gonna put the
exactly,
average.
and you know what they say about averages, you can, drown a lake that has an average of 2 inches of water. What it was supposed to do was give a sort of consistent list of services and supplies, and it was supposed to sort of help in accounting and cost allocation and regulatory reporting, which whenever the government's involved, that happens. And it was supposed to be a reference point for complex contracts. But what it actually did was not that.
What did
What do
it
you think
do?
happened, Bill? Do
I
you
don't
think it
know.
achieved what it was supposed to?
No?
Yeah. No, no. So prices became sort of inflated anchors for negotiation. Like they always say that talking about department stores marking up prices just before Christmas so they can have discounts for Black Friday.
Right.
Okay. And I saw that on Amazon. I was trying to buy a hard drive for my server and the price was really high. And Amazon has a price history. So I looked at the price history and I said, whoa, it's at the biggest price now. And then all of a sudden there's 25% off sales. And I said, yeah, even after 25% off, it's still more. It not only did that, but nobody expected to pay the full charges. People that were uninsured and out of network patients, often they were exposed to these prices, scaring them into having an insurance. And when you see the insurance explanation of benefits, it says, oh, yeah, the hospital charged this and we paid that. We saved you so much money. Aren't we heroes? Well, no. You knew in advance what the prices were going to be. And then you had a wild variation of pricing. And I've told you about when I looked at the state of Tennessee, over $2.7 billion of billed charges. The one I quote again and again, CT scan of the abdomen, the average was $635. The high was 19,800. So we had these huge variations. It was, it was and is still ridiculous. So, that's what Chargemaster actually did.
Yeah. Well, then walk us through maybe the life of a bill,
Okay.
for a patient.
Not a Bill Tucker.
No, no, no,
medical
no,
bill.
nor are they one big beautiful bill, as I often call myself
Yeah,
personally.
yeah. Well,
No, the actual hospital bill. Yeah.
there was a study that was published in 18, Journal of American Medicine, JAMA. It was authored by Kevin Schulman, a few others. I will think of them. It was a very good study. And what they did is they studied the administrative costs and the time required in billing. Okay. Now, since then, I know it's increased. So they tried to map all of the steps that are required, that there were 43 steps, a lot of human touches, a lot of faxes and rekeying and so much room for error. That's just one part of the big picture. And what we should do, Bill, is have a deeper dive into that later and look at some of the other things right now. But the life of a bill is important because it defines the waste in healthcare. We hear commonly that it's about a third of the cost. And I had Dr. David Schenker from Stanford on a few episodes, and he was part of that study, the Stanford part of that study, the life of a bill. And he said on an episode that we spend $1.7 trillion on administration and billing, and we could easily shave off $1 trillion. Okay. $1 trillion a year.
That
Okay.
is fascinating. Yeah, because Ralph, I over the years have spoken to a lot of doctors and health hospital administrators, and they made a similar kind of comment to me. They're talking about you can't believe how many billions of dollars are awash in the system,
Yeah.
and I'm like, what do you mean? And I've never been able to really fully understand it, but let's just stay with that for a second.
Yeah.
It's for it to be identified that clearly, like someone's saying, basically over half the cost in administration could be eliminated.
Oh yeah, easily. Two-thirds, I think.
Wow.
And Dr. David Himmelstein and Steffi Woolhandler they've done a lot on bankruptcies in America. And one of the studies that I love that they've done is the growth of administrators versus physicians. Okay. And in a nutshell, between 1970 and 2024, administrators have grown by 4,800%, and the number of doctors have grown by about 250 to 300. Okay. So this graph that shows this mountain of administrators growing while physicians, were here. So when we talk about the price of healthcare, it's largely the administration bill.
That's stunning. That's stunning. Wow. Because I think most people probably, if you ask them, say, "Oh no, most of most of my money is going to pay for the salaries of doctors and nurses and the actual procedure," and that's not the truth.
Yep. No, absolutely not. It isn't. I mean, I
I
don't
mean,
know.
how do we get here, though? I mean, that's the question, Ralph.
Mhm.
How did we get to this point?
Well, there were a lot of things that influenced that. The Chargemaster is this made up fictitious price. And I kind of envision, somebody throwing a dart, if, at a pricing chart
Right.
and say, oh, let's have that be the bill charge, right? The important part is what's called the allowable charge. So
Okay.
the allowable charge is what the insurance companies should pay. Now, I use the word should, okay? And that's important because that allowable price is like after the discount. And the discount could be 10%, it could be 90%. At the end of the day, it doesn't matter how much the discount is, it matters what the allowable is. And from insurance company to insurance company, they vary a few percent, like not hugely. But the Chargemaster has, as I said, 3,000 plus percent variation. As
Yeah.
the Medicare, I had talked about a few minutes ago, as they paid, the average that it cost hospitals, a lot of hospitals were losing money on Medicare. So
Hmm.
cost shifting began. So they said, well, if we're going to lose money here, and then, they leveraged the charge master, started to have Medicare, when they adopted DRGs, they started to shift costs. And the cost shifting meant that private payers and insurance companies would pay more. Okay. And that grew more and more and more. And of course, Medicaid numbers are even less than Medicare.
Right. Yeah.
So the more a hospital accepts in Medicare and Medicaid patients, the more they get underpaid on those, the more they have to shift costs.
It makes sense. It makes sense because you can't sustain yourself as a company, as a corporation or an entity
Mhm,
if you're
mhm,
always losing money. I mean, which explains to me why there are some hospitals that I have been a patient in. I was trying to
mhm,
figure out a right way to put it, where they I get frequently get solicitations, especially this time of year because this is toward the end of 2025.
mhm. Yep.
I get the solicitation saying, we hope your experience was great, and they're
Mhm.
asking me for donations to the hospital.
Donations. Yeah.
Yeah, because
Okay.
it's like, to your point, if you're gonna accept less money or below
Mhm.
cost over here,
Yeah.
you're going to shift it, and
Right.
you're gonna
Right.
shift it to the insurance companies or private
Mhm.
insurers, and
Yep.
say, and even then, I suspect, based on the solicitations for donations, that's
Yeah.
not working out.
Yeah. No, 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 it's not. And, the employers, a lot of employers started to focus on discounts. I remember one time when I lived in Tennessee, I was bidding on a certain contract and they said part of the criteria is the amount of the discount. So I approached a local hospital and I said, look, I've got like about 8,000 people in this county. What kind of a, discount do you normally give to like big insurance companies? They said, about 50% plus or minus two or three. Okay. Well, if you had a direct contract, could you give more? Oh, yeah, yeah, yes. Oh, great. Okay. How much? How much do you want? And I just threw out a crazy number and I said, 75%. They said, yeah, yep, we can do that. I said, what? Wow, I got this in the bag. Insurance
Right.
companies get 50%. Okay, I've got
I'm
this.
gonna get 75.
But here's what they told us. Here's what they told me. The At that time, and this was going back more than 10 years, 15, years ago-ish, the charge master was based on 400% of Medicare. In other words, 4 times as much as they get paid by Medicare,
Right.
and the discount is 50%. So that discounts it down to 200% of Medicare. Okay. Now, they said in order to give you a 75% discount, your charge master is going to be 800% of Medicare. And then we'll take off 75%. And I said, okay,
Wait a
wait, let me
minute.
do the math here. 800 times 0.75 equals 200. We still get, yeah, you just want to, so it really illustrates the amount of what's a kind word that I can use, the UTP in the pricing, it's crazy. So the discounts was something that people focused on, but it had nothing to do with the actual spend.
Which, number one, that's just mind blowing. I got to sit here and
Yeah.
take a second to think about that
Mhm.
because it's funny. I think that if you ask people the way they think
Mhm.
healthcare works, should be that
Mhm.
insurance companies are coming in and saying, hey, we're competing against other insurance companies, and this would effectively control
Mhm.
the cost of what the hospital charges.
Right, right.
And so that the old HMO versus PPO, and we
Mhm.
can guarantee you a certain amount of payment, and this is you're going to know what you're going to get.
Yeah.
Most people, I think, Ralph would say, yeah, that's the cost control right there,
Right.
right? But
Right,
that's
right.
not, is it?
No. No. No, 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 it's not. So what happened is, like we talked about, the HMOs and the PPOs and the discounted pricing, but what the allowable kind of charges were is number one, their discounts off of fictional amounts, but they really became, yeah, like you said, price controls, the provider specific ceilings. Frequently, what happens is insurance companies and third party administrators pay more than the billed charge. Okay. So if the billed charge, the Chargemaster is, let me just throw out a number. Let's say it's, $10,000. Okay. And the allowable, let's pretend that that's $5,000. They bill 10,000. They'll actually pay 12. I've seen it happen, Bill. I have seen them pay more than billed charges. And why would anybody pay more? Then they say, well, for that procedure, the allowable was actually 12 and they only billed 10. So, it's crazy. So the discounts are not consistent procedure to procedure. So what ends up happening is that patients going in, they really have no idea what the costs are going to be. And they're scared, right? Be-
Yeah.
yeah.
Well, yeah, that's understandable.
uh,
Because
eh,
what's weird
mhm,
here is that you've got a broken free market system, because in
yeah.
a free market
Yeah. Yeah.
system,
Yeah.
ideally,
Yeah.
we'd know what the cost is going to
Yeah.
be and we
Yeah.
have an idea what's going on here.
Yeah.
If you've got pricing if it's the pricing mechanism is
Mhm.
broken, there is no
Yep.
market force at work in here, it
Right.
seems like.
Yep. Yeah. Yeah. Well, the Chargemaster, as I said, they were used as leverage for negotiation, not transparency. Once the prices stopped functioning as signals, the business couldn't reconcile, the costs anymore. So it became WTP. What's the price? I mean, I don't know it. So there have
Wow.
been, unfortunately, so many games played, and it has just not it's made the cost so much more expensive.
Yeah. Which begs the question of, where does the money
Mhm.
actually go? And
Well,
well, that's going to be the next episode.
mhm. Yeah.
Which is a reminder to you people listening, hit
Mhm.
the follow button if you're not a subscriber already, because you want to hear this next one. Where does this money actually go? Ralph will explain that in episode
Eh
3 of this.
yeah.
Also, Ralph, I want to remind people, you were talking about your interview with the doctor
Mhm.
from Stanford. That is in the archives
Yep.
of the Benefit
Yep.
Whisperer. So, you know, take your time in between this episode and the next one to go
N
listen
n
to those interviews.
Let me say just to David Schenker is a PhD doctor, not a
Okay.
not a physician, right?
Yeah.
He is a doctor though. So, I had 3 fabulous episodes with him on the cost of billing and insurance. And Bill, I've talked to you about how the bill, I keep saying your name. You have a very popular name.
Man, let me tell you,
Yeah.
people
Yeah.
get mail from me all the time from me. Here's a bill.
And you know how bills arrive weeks and months after the system. So
Yeah.
we have no idea. And bankruptcies every minute of every day. So, yeah, where does the money go? That is the question that
Yeah.
we will answer or get into
Get
on the
into.
next episode.
Because if we could, yeah, we'll get into that on the
Oh,
next
yeah.
episode.
Yeah.
In the meantime, Ralph, if anybody's been listening to this podcast and would like to reach out, have a conversation with you, talk to you in terms of like managing their corporate
Hmm.
healthcare
Yeah.
costs, because that's one of the things you do is you work with
Hmm.
companies to help reduce
Yes.
the price of what they pay for healthcare
Mhm.
while hopefully not diminishing any of the coverage for their employees. How would they get a hold of you, Rob?
Well, and I've given, on past episodes some examples. I've had some newer ones. There was a very expensive cancer drug that cost $360,000 a year. We were able to find a program to pay for the entire amount.
Wow.
There's examples after examples where advocacy helps. So where can they contact us? One of our biggest saves was $28 million a year just on the pharmacy spend. Okay. One company, we saved $10.5 million over 4 years. It was a smaller company. So if they want to reach me, Ralph at thebenefitwhisperer.com, or you can call April or visit fixmybenefitsnow.com.
Excellent. So remember, subscribe, give this podcast a like, and please, if you find this podcast interesting, compelling, useful, tell people about it. Please. Word of mouth promotion, person to person. One of those deals?
Yeah.
Human to human.
I love it. Yep.
Recommendations. We'd very much appreciate it because word of mouth promotion is the most invaluable tool that there is.
Mm-hmm. Yep.
Until next time, I'm Bill Tucker on behalf of Ralph and everybody at Benefit Whisperer. Thank you for taking the time to listen. And we'll catch you next time on Where Does All This Money Go Anyway?
Yeah. Sounds good, Bill. Great seeing you again.
Good to see you.
Yeah.